Recording in progress. Good morning. It's great to see so many participants joining us today virtually. My name is Anita Sankrin-Piskin. I'm the Vice President of CHOP's Primary Care Network, and I have the honor and privilege of serving as the board chair for the Coalition of Orange County Community Health Centers. Before we begin this morning's program, I'd like to take a moment to acknowledge the passing of Senator Dianne Feinstein, a leader and advocate for women's rights, marriage equality, and the environment. She protected women against domestic violence and assault by reauthorizing the Violence Against Women Act in 2022. May we please take a moment of silence to honor the passing of California's and the nation's longest-serving female senator. Thank you. Thank you all for joining us for Coffee Connections this morning. I'm so excited that we are gathering today for what will be a very important and timely conversation, advancing equity, embracing reproductive health as essential to holistic care. As many of you know, the Coalition of Orange County Community Health Centers is a membership organization that represents the interests of the health centers, such as mine, that serve our community's most vulnerable patients, those who are either uninsured or underinsured and face disproportionate risks due to structural racism and discrimination. The Coalition's membership includes 26 community health centers, collectively operating over 70 sites throughout the county and serving over 350,000 patients with over 1 million visits per year. That's pretty staggering. The members, many of whom are joining us virtually today, provide quality preventive and primary care, oral health care, mental and behavioral health, program eligibility, health screenings, food and rental assistance, and much more. For over 49 years, the Coalition has engaged in the work of building a healthier Orange County. The Coalition believes that for our community to thrive, everyone must have equitable access to quality, affordable healthcare, regardless of income, ethnicity, or immigration status. Raising awareness, providing education and training, and facilitating thoughtful and often uncomfortable conversations to enable change is integral to the work of the Coalition. With that in mind, the team has put in place the Coffee Connection events, which are designed to unite and connect, educate, and drive action of health center workforce, partners, Coalition staff, policymakers, and other stakeholders on key healthcare and public health topics and issues impacting the Orange County communities. Through these events, the Coalition and its board strives to create a platform in which we have a shared understanding and common language, as well as a space for continued collaboration to further drive actions toward a healthier Orange County. As such, I'm truly delighted to welcome you all to our Coffee Connections event today, where we will be delving into a topic that holds immense significance, not just here in Orange County, but also in the state of California and nationally. Today, we gather to discuss the critical topic, integrating reproductive health and primary care, a topic that is both timely and of paramount importance. As the board chair of the Coalition, I'm acutely aware of the pressing issues that affect our community and the need for us to come together and have these rich and actionable discussions. Reproductive health and primary care are cornerstones of healthcare, and their integration is not just a matter of convenience. It's a fundamental step towards achieving comprehensive and holistic healthcare for all. In closing, I want to express my gratitude to all of you for being here today. Your presence and your commitment to this cause are a testament to our shared dedication to improving the health and well-being of our community and nation. Let's make today's Coffee Connection event a truly transformative experience. With that, please let me introduce Isabel Becerra, President and CEO of the Coalition of Orange County Community Health Centers, who will be our MC for the event. Isabel?
Thank you, Anita, for your inspiring welcome and opening remarks. We're so excited to have you as our board chair, and we're grateful for your leadership, as always. So as Anita mentioned, today's topic is complicated, and there are so many misconceptions and information that we hope to dispel with our amazing group of speakers this morning. Here in Orange County, we're no strangers to the unique challenges and opportunities that our community presents. Our county is diverse, vibrant, and dynamic, and we are proud of the progress that we've made in addressing healthcare disparities and advancing equity. However, we cannot ignore the fact that there is much work left to be done, as we all very much know so. And in order to do so, we need to unite together to create a shared understanding, raise awareness, and explore ways in which we can further integrate reproductive health to enhance the delivery of comprehensive, value-based, and inclusive healthcare, with a specific emphasis on promoting equity and driving excellence in patient-centered care for all individuals. Through today's session, we hope to address the following: an overview of reproductive health in California and across the nation. We want to dispel misinformation and cultivate educated conversations to broaden our perspectives on reproductive health. We want to expand awareness of the full spectrum of reproductive health, dispel the narrow focus on abortion, and foster a space for well-informed discussions and more comprehensive understanding. And we want to explore how integration of reproductive health helps enhance the quality of care. So in the next 2 hours, we will have the privilege of hearing from experts, advocates, elected officials, and leaders who have dedicated their time and hearts to this cause. We will engage in meaningful dialogue, share insights, and explore innovative strategies. I encourage each of you to actively participate, share your thoughts, and collaborate with one another. It is through these connections that we can drive real change and make lasting impact. Now, with that, I'm so excited to introduce our keynote speaker, Amy Moy, who's co-CEO of Essential Health, an organization whose mission is to champion and promote quality sexual reproductive health, healthcare for all. Essential Health Access provides a wide range of programs and services, including clinic support initiatives, provider trainings, advanced clinical research, advocacy, plus consumer awareness. And as co-CEO of this organization, Amy provides overall leadership and guidance to advance Essential Health Access mission and strategic priorities. She directly oversees the organization's fund development, federal, state, and regional policy efforts, communication activities, and patient education and consumer initiatives. Please join me in welcoming Amy. Amy, welcome to our Coffee Connections event. The mic is all yours.
Thank you so much, Isabel, and thank you to you and to your team for having me this morning for this important conversation. I'm really looking forward to an engaged dialogue. I also want to give a shout out to my partner, my co-CEO, Nomsa Kalfani, who will be joining the conversation a little bit later. And again, thank you for joining us. You know, I think that the title of this event today actually really says it all, that expanding and ensuring access to reproductive health care is essential. It's essential for advancing equity. Reproductive health is essential for individual, family, community health, and well-being. And it's really important that we talk about why we need to make it part of holistic care, as it's such a fundamental part of our lives. So I'm going to go ahead and test my skills at sharing my screen. And here we go. We can run through a few slides. How does that look?
That's great.
Great. And, oh, jumpy. So I just wanted to, provide just a quick setting the stage as well. We talk about how, and today we're going to talk about how reproductive health and justice are essential, and an essential part of our individual, family, and community well-being. But despite this, sexual and reproductive health services, providers, and patients continue to face stigma, as well as these medical services that are so basic to our holistic care continue to be under political attack. And systemic, as was mentioned earlier, systemic structural barriers, racism, have all led to inequitable access and health outcomes. And this conversation is really important because I think that together we can come up with some solutions to help shift the tide. So first, let's set the stage by what are we talking about when we talk about reproductive health? So, reproductive health is the state of mental, physical, social well-being, and all matters related to our reproductive health system. You could see the World Health Organization's definition of sexual and reproductive health. But the services that we're talking about do run a broad range of services, including services related to pregnancy, whether it be preventing pregnancy by ensuring that folks have access to a wide range of birth control methods that meet their individual and unique health needs and desires, to help folks space and plan pregnancies and prevent pregnancy from occurring if they're not interested in getting pregnant now or in the future. It also includes fertility treatment for folks who are hoping and desiring to start a family. It's also treatment for pregnancy, whether that be prenatal care, maternal care and delivery, care related to early pregnancy loss and miscarriage management, as well as abortion services. Reproductive health services and related services could also include STI, sexually transmitted infection, treatment, prevention, and HIV screening and prevention, as well, as we know that those issues can be aligned to our reproductive health and fertility as well. So reproductive health, again, is essential. You'll recognize the theme throughout the talk today. And again, these services that we just talked about are among the most common healthcare needs of women of reproductive age. And remember, people can be, and also women and people who can get pregnant of reproductive age. People who can get pregnant, that could span over 3 decades of their lives. So it's essential that we make sure that they have reproductive health services available to meet their reproductive goals and help them thrive and plan their families and their futures. And delaying these essential services can have serious consequences, both on an individual's physical health and their general well-being. You'll see here a good kind of word cloud of all of the pieces that go into what we talk about when we talk about reproductive health. It's really important to note also, all healthcare and access to healthcare is critical throughout an individual's lifespan. But here are just a few key points about why reproductive health in particular matters. So access to birth control is linked to greater educational and professional opportunities and increased earnings. Wages increase to the availability of birth control. Folks who are able to make their own reproductive health decisions have more likelihood of positive life plans and being able to achieve their goals related to education and employment. And that's more likely to occur than people who are denied access. And in the US, limited access and restrictions are associated with outcomes including high infant mortality rates and increased odds of preterm birth and low birth weight. But when it comes down to it, we could talk about statistics. We could talk about how reproductive health access is, across the spectrum, is so fundamentally connected to not only our health and well-being, but our economic security, our educational and career opportunities. But when it comes down to it, the real root and the heart of it, and it is the heart, and we have to remember to keep the heart in healthcare, keep the heart in access, and think about the individual lives that are seeking access to care and the folks that are accessing to care. And we can't say that we are free if we can't control our own bodies. Reproductive rights and the ability to decide if and when to have children, to have bodily autonomy and make individual personal decisions about our health and our futures is a fundamental human right. And I will just say kind of period. But we will kind of be talking more about what exactly that means and the real implications, the real life implications for denying people the right to have that freedom, particularly in a country that flat raise a mantle of individual freedom. The freedom to control our own bodies is fundamental. I also wanted to just make sure that we note that, when we talk about reproductive health, there are frameworks about reproductive health, which are those services that we talked about, that are the clinical services. Then there's reproductive rights, which are kind of the legal rights to accessing health care. And then there's reproductive justice, which is a framework developed by Black women around the human right to control our sexuality, our gender, our work, and our reproductive lives. That comes from a more intersectional, comprehensive lens, with the belief that our rights can only be achieved when everyone has the complete economic, social, and political power and resources to make decisions about our bodies, families, and our communities in all areas of our lives, including the right to have children, the right to not have children, and the right to nurture the children that we have in a safe and healthy environment. So this is information from In Our Own Voices, the National Black Women's Reproductive Justice Agenda. And I just want to call out and shout out that here in California, we're really fortunate to have a robust reproductive justice coalition and partners that are doing amazing work to advance reproductive justice at the state and national level. So, we wanted to kind of start off with just setting the stage and the context about what we mean about reproductive health and rights in the broad spectrum. And this is such a timely conversation because right now, where we are across the country, if you look at this devastating map, there are huge swaths of the country where that freedom to make individual decisions about our bodily autonomy and our reproductive health decisions has been denied, that there is now state-sanctioned and state-forced pregnancy impacting millions of people across the country. So you'll see the red, the dark, deep red to maroon shows states that are most restrictive, which means there are total abortion bans. And then there are, have severe restrictions that are so limiting that in reality, it's a complete abortion ban, which means that individuals in those states are unable to access all reproductive choices in their state. And we'll talk a little bit about the implications that has even beyond abortion care. And then we also see that there are several states as well that have very restrictive laws, and this map is continuing to change. This is the most updated information available now from the Guttmacher Institute. And you'll see we're very lucky here in California. We'll talk about all of the actions that California has taken to protect reproductive health. We've also made great strides in advancing reproductive justice as well. And we'll talk a little bit more about that in a little bit. And I know that some people are like, wait, why is California not the most protective? And I think that Oregon has passed one measure that we haven't yet, but I think that when we look at our agenda for this year, we might get into, and we have the governor sign a new package of bills. We will hopefully, I think, be moving into that most protective status. So when we saw the map, that gives a visual of the impact and the huge, again, swaths of the country where right now 36 million, it's estimated, women and people who can get pregnant of reproductive age live in states that have or are likely to ban abortion. And I will say that if there is a mention of women in these, it's because that is the statistics and how they're called. And we do recognize the women and other people who can get pregnant, and in being inclusive with our language with intentionality. And if there are mentions specifically of women, that's based on the statistics that were and the research that was gathered. So out of these 36 million, particularly women of people born female of reproductive age, 12.5 have lower incomes. And this is an estimate and face economic security. I mean, these are large numbers. 15.8 million are already mothers with young children, and 2.9 million identify as disabled. And while people from all backgrounds are impacted by these harsh, I would say, human rights violations in these states, We know that intersectional and structural barriers and systemic racism could create particular challenges for BIPOC communities, people with low incomes, immigrants, and youth. So people who can get pregnant and experience economic challenges are, of course, disproportionately were likely to live in states with bans and severe restrictions, and then also have greatest difficulty in traveling to another state like California to get the care that they want to need, with greater burdens, with not having to have time off from work, wondering about childcare, not having, again, this paid leave, or worrying about the economic stress, and not knowing about some abortion funds or some funds that are available to help get them the care that they want and need. Although we'll talk about the progress that's been made in that area. Black and Native American women are the most likely to live in these 26 states with the largest restrictions and the most severe restrictions and bans. And Latinas are the largest group of women of color harmed by bans. And that's largely because of immigrant status and already feeling like they are, and these communities are already facing overcriminalization and surveillance and, travel because of documentation status and other barriers make it very difficult to access the care that they want to need. And of course, when you think about ability to go sometimes in some, if you think back at that map, travel across several states, that ability to travel those distances face particular challenges, of course, to young people. So what is the implication and the impact? Just to kind of take a moment, it's important to pause. And when we see like the map, when we think about the numbers, the millions of people and lives impacted, what does that mean? And how is that kind of playing out in people's everyday lives? That means that women and pregnant people who face significant restrictions and are unable to get the care that they want and need will face negative consequences for their lives, their life plans, their health, their economic security. Pregnant people are more anxious than ever about their privacy and their personal health information and face heightened risks of criminalization. People with desired pregnancies are also harmed by abortion bans because of delayed or denied care for pregnancy complications, because providers have been chilled. There are, because of these severe restrictions that have some vagueness about what is allowable, providers have been chilled and placed in an untenable position of not knowing if the services that they know that their patients want and need, if they deliver them, would they be within the bounds of the law? And that leads to them fearing and being in a difficult position of providing less than the standard of care. And that has also led to providers leaving those states. So providers who are trained to provide the full spectrum of sexual and reproductive health, our studies have shown, and many reports have shown, are exiting those states because they are unable to provide the care that they know that their patients want and need. And that impacts reproductive health services across the spectrum as well. So fortunately, we could shift gears to here in California. We are very fortunate from our leadership, from Governor Newsom to our state and the whole administration, our legislature, to our healthcare delivery system. There's strong support for and acknowledgement of the essential role that sexual and reproductive health services play in our everyday lives, including abortion. So here in California, we have said loud and clear, we even on billboards, this one is by one of our reproductive justice partners, Black Women for Wellness, that abortion is and will remain legal in California. I know the governor has put billboards out in some banned states, and other partners have, put out in, loud and clear that abortion in California, it will remain safe and legal and will be a safe haven for people who are in need of those services within our state, for people who live here, for California residents, as well as those who are forced to travel to get the care that they want to need because of bans in their home states. I will also say that it's important to note that we've heard that even here in California, because of the widespread, even in many parts of the media, from social media to the news, that the overturning of Roe v. Wade has been covered widely, and there is a very concerted misinformation campaign that's out there that has led to confusion of legal rights and legality, even here in California. So it's important that we all continue to recognize that and continue to share that here in California, we are a reproductive freedom state and a safe haven for folks here and those forced to travel. And when we talk about a reproductive freedom state, we as a movement with over 40 advocates and partners and healthcare providers, the Women's Legislative Caucus and other leaders came together and thought, well, what does it mean to truly be a reproductive freedom state? So the California Future of Abortion Council was formed in 2022, soon after Texas's Senate Bill 8 was enacted, which was around a year before the Supreme Court took action to strike down Roe versus Wade and eliminate the right and the ability to and the requirement to provide access to abortion services nationwide. We saw the writing on the wall, and so advocates did come together to think about what does it mean to be a reproductive state, and put together over 40 recommendations that were, and many of which became bills that were introduced in the legislature, as well as budget requests that were made to include in the state's budget. And I'm very happy to say that and share that there was a historic and monumental $200 million invested in sexual and reproductive health care in the state budget and for fiscal year 2022 to 2023, in addition to creating some essential new programs and grant programs that would support and expand the sexual and reproductive health provider workforce with funding for training, being able to expand access points through infrastructure investments to cover community education and outreach, as well as some programs that Essential Access has the privilege to be administering that we'll go into detail about around looking at specifically access and the abortion care infrastructure in LA County, making sure that there are services available at no cost for abortion and contraception for those who need it, as well as practical support funds to make sure that folks are able to get to the clinical services that they want and need. The $200 million investment also included investments in family planning and covering a $10 million shortage from a cut in federal Title X family planning dollars, and some other key investments in sexual and reproductive health, including coverage of the HPV vaccine in the Family PAC program for folks that are over 26 years old and it's clinically indicated. There was also a robust package of 15 bills passed, which is incredible, and that really led the nation with models that have been mirrored and adapted in other states that cover things like provider and patient protections and looking at provider and patient privacy, establishing some of the grant programs that were established that I mentioned, as well as looking at passing a resolution to put Proposition 1 on the ballot last year that was passed by a strong majority of California voters that enshrined the right to abortion and contraception in the California Constitution and the ability to make the right to make our own reproductive choices. And that is in our Constitution. We know that we're, again, very fortunate currently to have a leadership and government right now that's very supportive. In fact, strong champions of sexual and reproductive health care, but we wanted to protect and enshrine these rights for generations to come, and protect folks in California as much as possible if any nationwide bans were to take effect. I also wanted to note that the state took action to create a back-end system for federally qualified health centers to be able to get reimbursed for abortion care outside through Medi-Cal outside of the PPS rate. And I know for members and some folks joining in the group, I'm mentioning this relatively quickly, but when we talk about misinformation, that there are a lot of folks who have the belief that federally qualified health centers are unable to provide abortion care. And in fact, they can. It's just that it has to be separate and outside of the federal funding that is received that has restrictions on delivering abortion care. And so if folks are interested in learning more about that, I'm happy to talk about that. You can reach out to me. I have my email at the end. So I had mentioned some of the new grant programs that Essential Access has, the privilege to administer and be part of the helpers in this critical time to ensure that Californians and those who are forced to travel here can get the care that they want and need, and to bolster the capacity of our abortion delivery system across the state. So, while it was the SB 8 and the overturning of Roe v. Wade that really sparked the necessity of this robust and bold package of advancements when it comes to access to sexual and reproductive health care. The barriers to these services were experienced in California well before Roe v. Wade. So these new programs are not only for folks from out of state, but I just want to underscore that this is also for folks in California, because we know that even here in California, overwhelming majority of California counties lack abortion providers. We know that many folks still live in contraceptive deserts, which means that the ability to access a wide range of birth control methods is not available in many people's and California residents' local communities. So these are the 3 grant programs that Essential Access is administering under an umbrella of what we're calling the California Reproductive Health Equity Initiative. So this first program, the Los Angeles Abortion Safe Haven Grant Program, was really a pilot looking at what was expected that LA County, because of its proximity, and location, particularly to potentially, folks that might need to travel from Arizona, which is a restrictive state and could potentially become a ban state if the courts do not uphold the right to access and allow the state's ban to take effect, as well as just thinking about the large population in Los Angeles County of folks of reproductive age that might need greater access to a wide range of care, including abortion services. So $20 million of funding was allocated to expand the abortion care infrastructure in LA County. Funds were distributed to 21 grantees across the county, really looking at centering equity, whether it be the populations that are served that continue to face sexual and reproductive health inequities, as well as looking at communities being served that continue to face disenfranchisement and continue to have systemic barriers to access. We also looked at folks where there's geographic diversity as well, and $12.7 million were awarded over a 2-year period to support the program activities listed below. We also have a statewide uncompensated care grant program that was $40 million allocated over 3 years. The first round of grantees, we have 13 applicants that include different affiliates that we have the independent health centers, as well as a hospital-based outpatient provider across the state, with over $17 million requested, over $6 million in retroactive payments for care that was provided over the last year, and over $11 million for care that's projected over the next year. And we will be releasing a new RFP for folks who are interested next spring. And I just wanted to kind of note, we ask for stories, of course, because we can have information, we could collect data, but what does this actually mean? And so here are just some stories that we heard that also just go back to how essential these services are, and kind of what a heartbreaking situation it is and devastating for what people are having to go through right now. So this is a story about an 18-year-old patient from Texas, and the provider that submitted the story shared, thinking about the determination that this young woman had to show to get from Texas to California and all that she had to overcome. And if they hadn't been able to cover her procedure and support her while she was here and getting home, her life could have been changed forever. And that's why we talk about sexual and reproductive health care not only being essential health care, but it's also life care and life-changing care. And this is another story about somebody who works in a Sacramento region, that the number of patients they've seen from out of state is staggering. So many people who have to travel for so long. And then also, when we talk about some things around misinformation, who had encounters with entities that may be in their local communities that didn't provide full information and kind of delayed their access to the care that they wanted and needed. We also, again, administer the Practical Support Program with $20 million in funding to support care coordination and direct practical support, which includes transportation, lodging, ground transportation, and even could cover loss of wages and covering somebody to come with them. We know that it could be a very harrowing experience to have to travel on your own, particularly when you're traveling to seek medical care. We have applicants from, again, a wide swaths of the state, including Southern California, and 16 grantees will receive and have received over $4 million, nearly $5 million. And we also have a wide range of grantees where we really centered equity, thinking about the organizations that are reaching populations, whether it be unhoused individuals, looking at folks who are working with immigrant populations, and other communities that face particular systemic challenges to getting care that they need. These services can also provide doula support to make sure that folks feel that supported, respected in their sexual and reproductive health decisions. And we will be releasing another RFP again next spring. So for, again, practical support, here's another story with a 21-year-old patient traveling from Arizona that had to initially thought that they would have to drive home through the night after their medical procedure. And they were told that they could have a hotel room for the night near the health center before and after their visit, which you could imagine made such a difference in that person's life. But the vision of having somebody have to drive a long distance to get the care that they want and need, and then immediately turn around and drive through the night because of, again, maybe couldn't be away for long for whatever reason of having to get back to work, can't be gone for long for childcare, etc. So, we talked about some of the successes that established these grant programs, that established an initial set of robust bills. And this is a timely conversation. Just yesterday, the governor signed 8 of the Future of Abortion Council's 2023 priorities into law that seek to protect people from abortion bans in other states, protect reproductive health information and privacy, protect patients and providers, and expand the reproductive healthcare workforce. And in the governor's release, with announcing the signing of these bills, just sharing that we'll continue here in California to protect people and healthcare workers who are seeking and providing basic care. So going back to that theme that these services are and must be seen and protected as basic care. And if folks have questions or want more information about the specific bill signed, you could go to the Future of Abortion Council website, and you can also reach out to me and I can share additional information. So we have, come a long way. It has been 2 years since the overturning of Roe v. Wade. Over those 2 years, again, California has made great progress in being a reproductive freedom state, as well as, thinking about what that means, not only these abortion protections, but also expanding access to birth control and looking at also maternal and infant health and thinking about what is needed to make sure that all reproductive health decisions, all access to reproductive health care is respected, supported, and equally and equitably accessible for all, regardless of income, insurance status, or documentation status or age or who you love. We want to make sure that here in California, that sexual and reproductive health is seen as a fundamental right and basic health care, as we talked about. So I just wanted to show this slide because sometimes that's how I feel. I feel like we are just at the beginning. There's still a long road ahead. We've made progress, but there's still much to do when it comes to ensuring access. So we are moving forward, looking at advancing health equity and continuing to advance reproductive justice, bolster the local abortion care capacity, expand pathways to care by making sure that access is available in diverse health settings across the state, counter the rise in fake clinics that, again, we talked about a little bit earlier from that practical support story that do not provide comprehensive services, but do engage in some misleading tactics to bring folks in and delay their access to the care that they want and need. Also increase public awareness and reduce stigma and secure, stabilize funding streams moving forward. Because we know that it's a marathon, it's not a sprint. There's a long road ahead, and we need to make sure that we have all hands on deck and that we recognize that this broad spectrum of services is really life-changing. It impacts all aspects of our individual lives, our families, our communities. So it's important that we take away the stigma and stop fighting and politicizing these basic essential services and start caring for the individuals that need these services, that come to us and want to and need continuity of care delivered that meets their individual needs and respects their personal decisions. So as a mother, as a person, I will say, who has had a wide spectrum of reproductive health experiences, from wanting to prevent a pregnancy, having an unintended pregnancy, having a very wanted pregnancy, and now as a mother of a teen daughter. I thank you so much for your time and look forward to continuing the conversation and our partnership to make sure that everyone has the care that they want and need. Thank you, Isabel and team.
Thank you, Amy, so much for all that you and Essential Access do for us here locally and at the state level. Thank you for starting the road towards normalizing this discussion, for all. So for everyone listening in, to learn more about their work, visit their website at essentialaccess.org. Now, up next, we have our coffee chat, a panel of healthcare leaders who have successfully integrated primary care and reproductive health in their health centers. Before I introduce the full panel, I'm very honored to welcome Assemblywoman Kali Petri-Norris. Assemblywoman Petri-Norris represents the 73rd Assembly District in California, which includes the cities of Irvine, Tustin, and Costa Mesa. Assemblywoman Petri-Norris is a champion of community health centers in Orange County and is a leader in integrating reproductive health. Welcome, Assemblywoman. Thank you for joining us on this panel and for offering us some opening thoughts.
Well, good morning, everyone. It's an absolute pleasure to be here with all of you and to be working alongside you in this absolutely critical fight. We know that our reproductive freedom is under assault all across the country. And this really is, for me, and I know for so many of you, this is a scary time in America. But if I want you to take away one thing from today's conversation, it's that California is fighting back. We will not back down. And we are doing the work across the Legislative Women's Caucus and with our allies and other colleagues to protect and expand access to reproductive health care here in California. As our previous speaker highlighted just yesterday, Governor Newsom signed a package of 9 bills, our reproductive freedom package, and the result of our really important partnership with the Future of Abortion Council. And one of those was a bill that I authored to ensure that we protect access to reproductive health care by ensuring that providers are able to access malpractice insurance. So looking forward to this panel discussion. And as I said, we're not backing down, and I'm so grateful for everyone on this call for your partnership and your leadership as we ensure that we protect reproductive freedom for Californians and for Americans.
Great. Thank you so much, Assemblywoman Petrie-Norris, and thank you for your leadership. With that, let's begin our chat. As a reminder to all participants, you can ask questions to any one of our panelists via the Q&A function at the bottom of your Zoom window. We will leave some time at the end of the coffee chat to answer your questions. When inputting your question, identify what panelist that you'd like to address your question to, and if you'd like, introduce your name and include your name and your affiliation. So with that, I'd like to introduce our amazing panel of speakers. I'd like to please ask you to introduce yourself, providing your name and title, and tell us, why do you think reproductive health has been difficult to embrace for health and public health leaders as an essential component of holistic care? I am going to start with Assemblywoman Kati Petrie-Norris.
All right. And for me, I'm just going to come right out and say it. I think that the reason it's been difficult to have reproductive health care embraced as a fundamental part of holistic health care is because it's care for women. And the harsh reality of the world that we live in is that for centuries, we've been treated as like second-class citizens. And we see that in the way that healthcare providers interact with women across the board. And I think that the reality is very much rooted in the fact that we are, for all the progress that we've made and all the strides that we have made together, this is built on a system that was fundamentally misogynistic in its design. And so it continues to be a huge fight and a huge struggle for us to unpack that, for us to correct that, and for us to ensure that we can move forward in a way that women are recognized as fundamentally equal and fundamentally important as a part of the conversation in healthcare and across the board.
Thank you so much. Moving on to John.
Thanks. Thank you, Isabel. I certainly agree with Assemblymember Petrie-Norris. I think one of the barriers that we've seen with regard to reproductive health care as an integrated part of primary care is that the healthcare delivery system has historically been largely male. Thankfully, that's changing. We're actually seeing more women graduating from medical school today than men, as well as law school, although that's not relevant, but it's fact. But I think the other issue is that when people talk about reproductive health care, I think it often gets, for lack of a better word, sort of tinged with the stigma that's attached to abortion. And I want to, for the moment, put abortion aside. Amy spent a lot of time talking about it, and obviously it's a service we provide proudly. We are seeing folks from all over the country. And as Amy described, we never turn anyone away. We've helped people travel for care. We pay for their care, et cetera. But I think for today's purposes, I want to really focus on the rest of reproductive health care. Abortion is actually a specialty service. I don't anticipate that primary care practices are going to start integrating abortion. However, I would offer that if any health center who's listening is interested in expanding that care, we would gladly assist you in doing so. We are not concerned about competition in that area. We welcome all providers who are interested in doing that. But I think what's important is that there are other elements of reproductive health care beyond abortion where there's still some stigma attached and where there's some fear on the part of providers that if they are known for providing reproductive health care, that they're going to get the kind of attention that we get from an organized opposition that is mostly focused on the abortion services we provide. So I think that's one big issue, is that, it is not seen as a service that is comfortable for people to talk about, comfortable for people to provide. And so even when you get in the areas of STI testing and treatment, HIV prevention and testing, things like woman exams, et cetera, pap smears, a lot of practices are simply not set up to integrate that effectively in their primary care. And what ends up happening is that too ends up being designed as specialty care. And so, many women experience that they go to a primary care provider, but when they need their annual exams, particularly a pelvic exam, they get referred to an obstetrician gynecologist. And there can be many barriers to getting that care, especially for a low-income population. So I think that's one of the biggest areas. There are funding barriers as well, but I think I'll stop there because we're going to get more into the details later. But I think that's the general framework. And I think what's really important is understanding that if you're going to be providing comprehensive primary care to a population of people who are in their reproductive years, you have to provide reproductive health care to really be providing comprehensive primary care.
Thank you, John, and thank you for making that clear distinction and clarification of what else reproductive health care includes. Now we'll move on to Catherine.
Thank you. Hello, everyone. My name is Catherine Cohen, and I'm a staff attorney with the Center on Reproductive Health Law and Policy at UCLA Law. We are an interdisciplinary research academic center that brings together lawyers and researchers and students to produce interdisciplinary research to support discussions such as this. So thank you so much for having me here today. I really want to echo, I think, what folks on this panel and also Amy have already talked about this morning, which is the influence of stigma on making it difficult to integrate reproductive health care. And I think it's important for us to unpack that when we say reproductive health care, we don't always mean abortion, while also recognizing that restrictions on abortion limit access to all other forms of reproductive health care. In the past 50 years that the anti-choice movement has been working to overturn Roe, part of what they have done is, and successfully, is siloed reproductive health care out of a primary care setting or out of hospitals. I read recently and was shocked to find that before Roe v. Wade, the majority of abortions actually took place in hospitals. And I think that's an environment that we can't even really imagine at this point. And so the stigmatization of abortion has kind of pulled reproductive health care into this stigma as well, has siloed it separately. And as Amy mentioned, now you have anti-abortion policies that are also so vaguely written that they're having a chilling effect on other forms of care. And the providers are fearful for their licenses, for their liberty to be free from criminalization, to be able to provide comprehensive reproductive and pregnancy care services because of this political environment. So I think it's important that, yes, we're not just talking about abortion, but the environment and the policies that affect abortion affect people's access to all sorts of other reproductive care.
Great. Thank you so much, Catherine. Namsa.
Thank you and good morning. I would say, Namsa Kalfani, co-CEO at Essential Access Health, and plus one to everything that's already been said. And then I think I just want to add another little caveat to what's been said. I mean, navigating the healthcare system in general is hard, right? Whether you have insurance or you don't have insurance, that's already difficult. So then when you add this other layer of access to reproductive care, that's another level of difficulty, right? When you are thinking about what neighborhood you live in, what are the access of services that already exist in those neighborhoods, if you are Black, Indigenous, if you are LGBT, depending on your status, that adds a whole other level of difficulty in terms of what you receive, how you receive it, and where you receive it. And really, I believe that until we normalize access to the full spectrum of quality, affordable sexual and reproductive health care, we're not moving the needle, right? We are still in the same place and we're still having the same conversations. So whether it is deciding if and when to have a child, becoming pregnant and the care you receive while you are pregnant, especially if you are a Black woman, especially if you are an Indigenous woman, especially if you are a woman or a family, or someone who can have children, have a low income. So all of those things come into play. And if we don't address those things, and if we don't start to see it as essential care, right? It is primary care. So it shouldn't be this care that's off on the side. It should just be integrated into the whole full clinical process and clinical flow. Because once we start to put things into boxes, people get left out. Care then becomes decentralized, and then people don't get what they need, when they need it, how they need it, or with dignity and respect. And so until we really start to see people, the whole complete person, meet them where they are, and normalize that sexual and reproductive health care is something that everybody should receive, regardless of your zip code, regardless of what you look like, regardless of how much money you have.
Perfect. Thank you. Now we're going to switch back to Assemblywoman Kati Petra-Norris. Can you tell us about the creation of the first in the nation Select Committee on Reproductive Health in California? Why was this such an important action, and why was it important for you as a leader to become a member?
And thanks, Isabel, for highlighting the Select Committee on Reproductive Healthcare. And actually, I'm going to pick up in terms of the reason for establishing the Select Committee and the reason that I participated. I'm actually going to pick up, Namsa, on what you just said, which is that reproductive healthcare and comprehensive reproductive healthcare should be something that everyone in California has access to, regardless of your zip code, what city you live in, whether you're urban or rural or everything in between. And the fundamental truth is that that's not the reality today. And so that was the reason that my good friend and colleague, Rebecca Bauer-Cahan, established the Select Committee right when she was elected in 2018. And she asked me and a number of newly elected members to participate as part of that. And certainly the work of that Select Committee has become more important and more fundamental than ever since the overturning of Roe. And I will say one of the reasons we also established the Select Committee is because we were anticipating that was going to happen. And we wanted to ensure that California was prepared to respond. And for me, engaging in this conversation, engaging in that Select Committee is just our reproductive rights, our ability to access reproductive healthcare is so core. Reproductive freedom isn't just about reproductive freedom. It's about economic freedom. And it's about our ability to participate in every aspect of the world as equals. And the decision, as others have said, about whether, when, and with whom to start a family is one of the most profoundly important decisions that we can make. And that right is one of the most profoundly important rights. And as I said, so critical to being able to realize other rights and freedoms as well. So for both of those reasons, this, I think, has been a really important part of the work that I've been able to do in the legislature in the last 5 years.
Thank you so much for doing that and for representing not only Orange County, but the whole state and all women and the right to have access to these services. I'm going to move on to my following question, and this will be for Dr. Khalfani, Catherine, and again, Assemblywoman Kati Petra-Norris. So starting with Dr. Khalfani, from your perspective and the roles that you represent, what specific operational and policy gaps must still be addressed or closed to effectively integrate primary care and reproductive health in an effort to make substantial advancements in health equity at a statewide, regional, and local level?
Love that question. Thanks, Isabel. I mean, and it's a somewhat loaded question, right? Because I think it covers lots of different things. And, I'm not the policy person, so I'll bring in kind of my operations hat. We don't provide direct service at the present time, but I've worked in a fairly qualified health center, and I have the privilege now to support fairly qualified health centers and other providers under the Title X Federal Family Planning Program in California. And for us, we really have used this opportunity to help our network of providers integrate into primary care, really into their system altogether. And that, again, as I talked about, the more we normalize this care, the easier it is. And that doesn't mean that there's not funding barriers. It doesn't mean that there's not other challenges. But if nothing else, if we can start to normalize the service as primary, as essential, and not on the side. And also then what does it mean to integrate, right? So it is about integrating STI prevention. It is about integrating access to birth control, a full spectrum of birth control and options that meet people where they are. So it's about looking at funding, right? It's about looking at policies that codify progress, right? So that doesn't matter, hopefully, doesn't matter what administration is in place, right? But that we have policies and structures in place that don't harm. Because really what we've been doing is, for some folks, it's been a lot of harm. So how do we put into place policies, funding, education? How do we think about or reimagine what the workforce should look like? Right? I think we need to continue to make those advances because there's already a shortage of providers just in general, right? Then we know there's a gap as you move into sexual and reproductive health care and even beyond as it relates to abortion services. So I think we have to start reimagining what care should look like, right? Reimagining how what that experience should look like, because regardless of your power, your privilege, the quality of care, being able to afford the care should be equal across the board, right? I personally believe, healthcare is a human right. We all should receive it. We all should receive it at the same level. And then, I will say personally, I think it should be free, but it's not. So until we can move to a place where everybody gets what they need, when they need it, and how they need it, we are still at a place to try to get to this North Star of reproductive freedom, right? And so people need to be able to provide a service, even if they don't have the specialty services, as John was discussing, but at least be able to give people what they need in terms of information, in terms of resources, and at least the initial phase of service that they may need. Because if we don't, and I think what was shared earlier is, yes, earlier Amy talked a lot about abortion, but abortion issues impact access to birth control, right? It impacts sex education information and what's being shared, especially when you think about adolescents and the wide range of misinformation that they are exposed to, whether it's through TikTok, Instagram, or anything else. And so being able to actually provide accurate information so that when they walk through a door, they actually can get what they need and not end up in the four walls of a brick and mortar, and they think they're getting information, but they end up wasting time getting what they need, right? And so it's, again, about the stigma. If we normalize this and normalize our policies, again, we may have folks working in health centers that may feel very differently about a service being offered. We really have to think about the person in front of us. And if it is about my feelings, then no care would actually, right, get provided. So it's about really acknowledging the person in front of us, the humanity of that person in front of us, meeting and providing care with dignity and respect, and also meeting them where they are, right? Because if we don't do that, I think we're just spinning our wheels.
Thank you. That was amazing. Thank you for framing that in that way, right? So we continue to look at how do we normalize the topic of reproductive health so that it's equitable for all. Catherine.
Thank you. Definitely a +1 to everything that was just said. I want to, especially funding. I think, California has done an excellent job in the last 2 years, dedicating lots of funding, post-Dobbs, recognizing that additional funding for reproductive health care that isn't abortion is the same fight. And so I'd love to see that continued. I also wanted to echo the comments about workforce development, which is also something that California has made great progress on. And I'd love to see more policy and then more implementation of these things. Some of the California Fab Council bills that have been mentioned, that have been signed, are expanding scope of practice for advanced care providers, like nurse practitioners and physician's assistants, to be able to provide abortion care, and just having more implementation of these kinds of advanced providers providing repro care in primary care settings would be an excellent step forward. We've also been doing some research on pharmacist delivered services, which in some places would also require further legislation to expand scope of practice. But I think many people in the state don't know that pharmacists are able to prescribe birth control directly to their patients, but there hasn't been a lot of implementation. And so thinking of, how do we better empower the workforce that already exists to provide services? What training, what education do they need? We did a survey of pharmacists on this and found that one of the barriers to implementation of that prescribing was that they didn't feel adequately trained. They were, again, the stigma. They're concerned about wading into reproductive health care unless they're very, very sure that they can provide it adequately. And so what kind of education do we need for the existing workforce in addition to funding and programs to train the next workforce? One workforce bill that also happened in the last year was specifically training programs for members of underserved communities to be trained to provide care in those communities. And I think it's really important to also think about culturally responsive and cultural humility in care, making sure that the providers who are treating people who have been historically underserved are doing so in a considerate way. And as folks have mentioned in the past on this panel, responding to histories of systemic abuse from the medical system for particularly women of color, Black women, Latina women, even here in California. And so there's the provider side and educating them, but then we also need to go to the actual patients themselves and making sure, as Namsa said, we're meeting them where they're at, that we're providing the services that they want, that we're not just giving them the best form of birth control, but the one that's the most responsive to their particular needs and their particular desires for their reproductive future. And I think part of that too is education of to the public of what is available, this pharmacist prescribed services, other services, and another +1 for sex education for sure.
Great, thank you. Assemblywoman.
And I would really just echo a lot of what has already been said. And I think particularly kind of doubling down on the points that have been made about the need for investments in policy around workforce development. I mean, in California, we have done a tremendous job in protecting and expanding reproductive rights. But rights without real access become really meaningless. And even here in California, real access continues to be a real challenge. And I think people are shocked when they hear that it's something like, is it 40%? It's 40% of California counties don't have a single abortion provider, and 9 counties in California don't have a single OBGYN. And so if we cannot continue to find creative and practical ways to really address that huge workforce shortage, we aren't going to be able to deliver on the promise of real access for Californians. And so it was actually, Catherine, you mentioned the workforce bill last year that I carried. It was AB 1918, and that bill established the Reproductive Health Service Corps in California, and the goal of that really is to recruit, to train, and to deploy the diverse workforce of medical professionals trained in a whole spectrum of reproductive healthcare services, which will then be deployed and assigned to teams in underserved areas across California. So was really excited to work with the FAB Council on that proposal last year, and to have the support of the Legislative Women's Caucus and so many others to get that bill over the finish line and funded in last year's budget. And we're continuing to focus on ensuring that gets implemented effectively, and that we're able to start to meet the gap. But I think there's a ton of additional work that we need to do in this space. And I think that's both investment and additional funding, as well as continuing to think through how do we expand scope of practice in ways that are sensible, and help us meet the huge level of need that we're seeing in the state.
Thank you, Assemblywoman. That is so true. As we all know, the workforce shortage issues were prevalent before the pandemic. The pandemic pretty much decimated what was left of the workforce still willing to work just in general healthcare. When you add then the barriers to care for reproductive health, then I think it's more critical and more important than ever that we work on expanding that scope of practice for those that we're recruiting and those that are willing to stay and continue to do the work. So thank you so much for that. The next question is for John. John, from a delivery system perspective, what barriers or obstacles, both systemic and cultural, need to be overcome to achieve true equity in the integration of primary care and reproductive health?
So I would distinguish this question into two segments. I think there are external barriers that create problems for access. Some of those have to do, for example, with the fact that we have a very well organized and funded opposition that literally demonstrates pickets in front of our health centers on a daily basis. And so they're creating an environment that patients have to literally go through on a daily basis, and our staff, where they are harassed, intimidated, videotaped, yelled at. And the truth of the matter is, despite what people think of Planned Parenthood, 93% of everything we're doing is not abortion. It's preventive care, it's primary care, behavioral health care, gender affirming care, all the things we do beyond abortion. But the picketers don't distinguish that. And so a patient coming for a well exam gets the same harassment as a patient who is in fact coming for an abortion. So we have that issue. The other issue, and I know this is sort of an elephant in the room for some of the health centers involved with the coalition, there are a number of religiously organized health providers that have religious directives that specifically state that they will not provide reproductive health services. And not only do they often not provide them, they often don't make information available to their patients about where they can go to get those services. And so this is a real major barrier to care. And frankly, I don't know, this is sort of between CalOptima and those providers, but they are required to provide the full scope of care one way or another. And I don't think that's really being adequately managed here in Orange County in terms of how they're dealing with these organizations that have very specific directives prohibiting that they deliver that kind of care. And although the directives may not prohibit their discussing that kind of care, many of their providers won't do it. We have seen this in the past. We regularly see patients who do come to us for abortion services from those organizations come several weeks later in gestation because they have to navigate additional barriers to getting to us. So this is just a real problem. And truthfully, it's a growing problem because the truth of the matter is the Catholic health systems and the Catholic health organizations are expanding their scope in California. So I know it's a touchy subject, but I think it's a reality. The other issue that we see is that often, even when patients go to a non-religiously based organization, they feel judged about what decisions they might make. So if a young woman wants to go for a pregnancy test and is not sure whether she would want to continue that pregnancy if it's positive, she often endures the judgment of a provider who has personal opinions about that, rather than a provider who's willing to offer her the full range of options without judgment and in a compassionate way. And so that's a significant problem as well, more of an internal problem that I think we see patients having to overcome. And the way we know this is that 80% of our family planning patients, I'm not talking about abortion patients here, 80% of our family planning patients are enrolled with another provider in the system, but come to us out of plan for their reproductive health services, for their contraceptive care, their well woman care, and their STI testing and treatment, their pregnancy testing. And so I don't know what all the barriers are that they're encountering. Some of it has to do with being able to get an appointment quickly. Some of it has to do with attitudes. Some of it may have to do with the skill sets of their provider, that the truth is, although their primary care provider may have very good skills dealing with a range of other issues, they're not comfortable going to that provider for a pelvic exam. And so they have to go elsewhere. And either they would have to get referred to a specialty obstetrician gynecologist in that system, or they can come to us where we have next day appointments available, and they're going to be greeted warmly and compassionately and caringly and without judgment. So I think that those are the overlays that I think patients experience. And the same is true on the male side. They require STI testing and treatment. They require HIV prevention and HIV testing. And often that comes with a lot of judgment, particularly if they're involved in a same-sex relationship. And so, and then obviously there's complexity of patients who are coming seeking some sort of gender affirming care and the stigma attached to that. And so we see a number of folks, not just for the transition they're undertaking, but for their basic primary care. And again, they're coming to us because we're going to provide the care they need without judgment, where they find that they don't encounter that in the larger health system. So I think there are a lot of built-in barriers. And then beyond that, there are some funding barriers. And lastly, I think there are some equity barriers. I have mentioned to Isabel previously, we still see Depo-Provera. It is the second most popular form of contraception among our patients. And yet it is the only form of contraception that requires that a patient come in quarterly to get a very painful intramuscular shot. We are actually working with a private firm trying to develop a new delivery system that would allow them to do it themselves at home. But there are those kinds of barriers where there just hasn't been a big investment in new contraceptive and reproductive health technologies. It's just not an area of focus for a lot of health organizations. And so there haven't been a lot of new developments there. So there's that sort of wide range of, I think, barriers that exist, and it takes a concerted effort to overcome them. And again, because if you do focus on reproductive health care, often you feel you're going to be subjected to either the scrutiny or stigma or even direct opposition of folks who not only don't support abortion care, but often don't even support contraceptive care.
Thank you, John, for highlighting some of these very important topics that, again, create or augment to the barriers that already exist. And so we will definitely, I think this is why, again, we're here today to normalize the discussion, but to also highlight what are the solutions, what are some of the things that we could be doing to eliminate those barriers and to work better together to expand some of these practices. The next question is for all of the participants. And so as we come to the end of this moderated conversation, we want to center this last question on our call to action. So how do we unite together to better integrate the reproductive health into primary care, as has been discussed by almost all of our speakers today? And with that said, for many reasons that we have already discussed, integrating reproductive health in primary care is a tall order, and community health centers can't do it alone. So from developing the policies to operationalizing integrated care, there are many stakeholders involved. From your perspectives, how can we as healthcare professionals and community organizations collaborate more effectively to promote health equity through integrated care approaches? I'm going to go back to Namsa to kick us off.
Great. I think I used to say we move the needle by changing hearts and minds, but I realized you can't just do that. You also have to have sustainable action, right? And so that's about removing stigma, blame. It's about having policies that make sense for the people who actually need to receive the services. Is about making sure providers are equipped to actually provide care in a way that meets the needs of their patients. I think I shared before, my North Star is reproductive freedom, but we have some ways to go before we actually can get to that, right? And I think first we have to get to reproductive equity. And so when I think about the things that we need or where we need to stand up, it's across lots of areas. And, we really have to transform a system that should be responsive to all patients, and I use the word quite a bit, and I'm sure you all have heard this before, like no wrong door. So regardless of what they need, regardless of where they are, when they walk through the right door, they should get what they need. And so I think we have to move away from some of our old strategies. I think progress needs to look different going forward. And so we can circle back and look at what we've done before, but really we're in a different fight. The stakes are even higher. And so I think how we move forward has to look very different. And we have to have a long game. I think those that are against or have a different philosophy in terms of how they feel about access, we then have to really step up in lots of different ways. And I think we need to advance health equity and reproductive justice, and allow those who are often overlooked to really be able to go to scale in terms of their services, but also be seen and heard in ways that they haven't always been done before. Expand pathways to care, right? And it could be in different places. And I think what was shared earlier, whether it's through a pharmacy, whether it's through a Planned Parenthood, whether it's through a community health center, and then having the community-based organizations that are then partnering across the board, right? Because I think, Isabel, you said, none of us can do it alone. The demand is high. And until we really figure out breaking down those walls that keep us separate, we really aren't going to be helping those that really need the care the most. Increase public awareness and reducing stigma. I think that comes up quite a bit. I think we really have to counter, especially in California, the rise in fake clinics, so that people actually get, when go through the right door, they actually get what they need. And we know in lots of places they are ending up at health centers that are not giving them timely or accurate information. So we need to move the needle there. And then secure and stabilize funding systems. And I think that piece has been mentioned. And I think those are key things we have to think about as we think of a new age, of a new way of making sure that there is quality, equitable, and affordable care for everyone.
Thank you, Namsa. Catherine?
Sorry about that. Absolutely, I totally agree with everything that has just been said. I think I just am really grateful to be in this space today, because I think these kinds of spaces where you have policy folks talking directly to providers are a key thing that we need to be doing, rather than trying to make the solutions over here separate from the people working on the ground, seeing patients. And then similarly, we need to actually be responsive to the needs of the people. So I think we need more communication across policy and policy advocates, the people, programmatic development, and actual providers. But we also need better research and better information about what are the barriers for community members, and then to be developing policies responsive to those barriers. What are unnecessary restrictions on reproductive health care, or unnecessary silos between repro and primary care, that are preventing individuals in the community from accessing care, and then how can we lift those? And so, kind of leading with the value of those closest to the problem are closest to the solution. We can't sit here and not talk to patients and try to develop a solution. And I think, again, we've touched on education for the public and sex education. I think that's a crucial thing as well. And it's just important for us to recognize that all of these issues are the same, are interrelated and are also under the same attack similarly. We've talked a lot about not hyper-focusing on abortion, and also on the way that those restrictions impact other access to reproductive health care, but also recognizing that, attacks on public education, attacks on gender affirming care, these are all sort of the same movement to restrict people's ability to choose what to do with their bodies, how to live their lives, how to form their families and their relationships. And so I think the more that we have communication and collaboration across these people who are addressing these issues, the better all of these services will be for people in California.
Great. Thank you, Catherine. Assemblywoman?
Well, so 3 things. And first, I just want to start by appreciating everyone who's been part of this conversation, appreciating all the work that you do and the role that you play. We've all got, we're all kind of a leg of the stool. And if one of those legs is missing, the stool can't stand up. And I'm just so grateful for the partnership that I think has become even stronger across the course of the last couple of years. And I think that, Namsa and Catherine highlighted a number of the challenges we continue to face and a number of the things that we need to do to move forward. And so I'll just highlight, I feel incredibly encouraged by the power of the collaboration that we have seen over the course of the last couple of years between community organizations, healthcare providers, and policymakers. And the reality is that we have had, I think, a tremendous and incredibly effective collaboration that's been forged, I guess, kind of on the battlefield, right? And under this horrific and terrible backdrop and this horrific threat. But I believe that that is going to make us even stronger as we move forward, because I think we've done a really great job breaking down the silos and ensuring that the policy ideas that are getting passed in Sacramento are connected with the needs of our community providers and, most importantly, the needs of our patients. So I'm actually feeling really excited about our ability to tackle these challenges, and just really excited about continuing to work with everyone who's a part of this call, everyone who is a part of the work that we are doing to ensure that we protect and expand reproductive health care across California, and that we ensure that we are delivering high quality, affordable health care all across the state, and continuing to work together to move California forward.
Thank you so much for that. John?
Yeah, hi, sorry. So again, I think this requires sort of a mixed intervention, and it's a little bit of a combination of a carrot and a stick. And so I think what we've seen with a number of various types of reproductive health services is that there can be significant barriers to those services if they are not adequately funded. A great example of this, I'm going way back, but when I first started here in the mid-90s, it was very hard to get a Medi-Cal patient obstetric care because it was terribly underfunded. We worked hard to get those funding levels up, and now it is actually not an area of real concern. We're very successful finding obstetricians who are willing to take even Medi-Cal patients for those services. So, but there are other gaps. Tubal ligations is an example. This is an underfunded service. We have a months-long waiting list for tubal ligations because we just can't get enough providers who want to take it on because it's not adequately reimbursed. So we're always working in Sacramento, working with our elected champions to try to make those changes, working with the governor and DHCS to make those changes. But there are still some gaps, and I think that creates a problem. And then the other side, and this is where the stick comes in, is that I don't think providers are held responsible for providing the full scope of care. And we see this in a wide range of services. An obvious one, this is not purely a healthcare delivery issue, but what we've seen, we passed, I think it was 2016, the California Healthy Youth Act to mandate that school districts provide comprehensive sex education after the 7th grade. And there are still dozens of districts not complying with this. And so we're currently working with Attorney General Bonta. We're putting a list together. We're doing the research. But there just aren't adequate statewide systems to enforce some of the expectations of healthcare providers in terms of providing this type of care. So I think it requires both setting an expectation that is going to be done, but it also means we've got to adequately fund these services so that it's not an unfunded mandate. The good news is, I think with the MCO tax coming, a lot of these services are going to be very well reimbursed. And, where there have been some gaps, particularly for the federally qualified health centers between, say, family pack funding and Medi-Cal funding, those gaps are, I think, going to be closed a lot with the MCO tax. And so at least that carrot will be out there, that opportunity for them to get adequately reimbursed. And that's always a big motivator for this kind of care.
I agree. Thank you so much, John. And thank you to all of our panelists, Assemblywoman Kati Petrinaris, John Dunn, Namsa, and Catherine for your engagement in today's coffee chat. And it was so insightful. You've hit on such critical points that I know that are shared among our healthcare system in our county, and for anyone watching outside of the county, I know that these issues are widespread throughout the country. And what a fantastic discussion on how we can come together to continue integrating the reproductive health and primary care for our communities. However, before we end this chat, we do have a couple of questions from the audience, and I will start with John. This is for John, but maybe others can address this as well if you have additional information. So the question is, I'm an advanced practice primary care clinician, and I do want to get trained on how to perform abortive care treatments and procedures. Are there opportunities to learn and train to offer more comprehensive primary care?
So the answer is yes. There are actually a number of Planned Parenthood affiliates that do this. We actually aren't doing this currently, but I'd be happy if this individual wants to contact us. We can assist them in finding that kind of training. There are a number of places around the state where there's a shortage of doctors to do abortion services. And so they've pushed more aggressively into the training of APCs to do that. We are very fortunate to be rich in that resource here in Orange County. So we just haven't gone down that road yet. But absolutely, that opportunity exists.
Great. Is there anyone else on the panel that would like to chime in on that?
I'll just mention the TEACH program. It's training in early abortion for comprehensive healthcare is an abortion training program, if folks are interested in that.
Great, thank you.
Just to add another resource, Essential Access has a medication abortion access program. So if anybody wants to particularly look at a medication abortion access, they can go to our website and find information about that program as well.
Great, thank you. The second question is for Assemblywoman Petrinaris. Do you think that legislation in California will ever include reproductive preservation and fertility treatment as part of covered benefits under Medi-Cal and/or third-party insurance?
Well, thanks for that question. And I know we have done some work over the course of the last few years to expand covered benefits in that arena. I think that there is some opportunity to expand the scope of that. And I think, as with all of these considerations, the challenge comes down to cost, funding, and how can we cover those costs in a way that ensures equity across the state, and fairness in our ability to actually deliver on other services as well.
Okay, great. Thank you for addressing that. In case there are any additional questions, please remember that you can log in your question in the chat. And you can also connect with us at the Coalition at coffeeconnections@coalitionoc.org. So we can then share any resources that any of our panelists will share or have shared with us to date. Please feel free to do so. Again, it's coffeeconnections@coalitionoc.org. So we're going to move on to our next session, or we're moving into the Reproductive Health in Action segment. And today we're joined by Krista Hollinger, Chief Operating Officer for Planned Parenthood of Orange County and San Bernardino counties, the second largest Planned Parenthood affiliate in the country. In her role, Krista has the privilege of overseeing clinical operations for the organization's 9 health centers in 2 counties, which provide reproductive health services and primary care 7 days a week. She also oversees human resources as well as strategic initiatives and programs to respond to community needs, such as Abortion Aid Program, which assists women from other states that need to travel to Planned Parenthood to receive abortion care. Krista has nearly 25 years of experience working in healthcare and public policy, including roles at UC Irvine Health and St. Jude. She's a lifelong advocate for reproductive justice and access to high-quality healthcare for all. So we're so excited to have you here with us today, Krista. Welcome.
Thank you. I want to thank the Coalition for including us and inviting me to participate in this. And thank you to all those who have spoken before me. That was a really, really good discussion. And I hope some of what I'm going to talk about is expand on that a little bit. And I hope that we'll just kind of add to, I wanted to get into a little more specifics about how to integrate reproductive health care into a primary care setting. So I'm going to hope that my technology works here and share my screen for my slides. Let's see. Okay, are the slides up? No? Okay.
Yes.
Talk for me. Great. Okay. So going to start off for my chat today, just to share our journey with our Melody Health program, which is our primary care program at Planned Parenthood of Orange and San Bernardino counties. and then talk a little bit more, as we've been chatting about for the last hour or so, about how reproductive health is primary care, and then share some best practices and learnings that we've had for integrating operations in both of those spaces. Okay, so Melody Health, we just celebrated our 10-year birthday. We are now going into our second decade of providing primary care at PPOSBC. We do comprehensive primary care services, and in the past year and a half have also began offering gender affirming care as part of our Melody Health program, as well as online behavioral health services. We provide primary care Monday through Saturday. Our health centers are open 7 days a week, but primary care is Monday through Saturday. And we provided at 7 of our health centers in both counties. So in Anaheim, Costa Mesa, Mission Viejo, and Westminster in Orange County, and then in San Bernardino and Upland in San Bernardino County. So we've grown quite a bit in those 10 years. Just want to show these are our enrolled lives. Starting from August 2013, when we started, we are now up to just under 18,000 enrolled lives for both counties, with far majority of those here in Orange County. So Amy gave this earlier as well, but just wanted to start by giving some definitions of what we're talking about today. So as she shared, the World Health Organization definition, reproductive health is a state of complete physical, mental, and I'm sorry, my all of the beautiful pictures there were showing up on my screen. Reproductive health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity in all matters relating to the reproductive system and to its functions and processes. And then to sort of take that a little further to this discussion about primary care, I wanted to share this, and I put the source here. I think this is a really good study that the Commonwealth Fund did in 2020. And they defined primary health care plays an essential role in responding to women's unique health needs through advanced age and in bridging care during life transitions, from puberty and reproduction to menopause. Achieving the vision of comprehensive primary health care for women is critical to improving health outcomes, bending the cost curve, and promoting health equity. So that's really what we've been talking about today, and how important providing care to women for their reproductive health needs is so integral to their whole person care for primary care as well. And just wanted to share, for our family medicine docs, they are trained in reproductive health care. Residents must have at least 100 hours. This is from the Accreditation Council for GME, who of course accreditates all family medicine residency programs. Or 100 hours or 1 month or 125 patient encounters dedicated to the care of women with gynecologic issues, including well woman care, family planning, contraception, and options counseling for unattended pregnancy. Now, our advanced practice providers are not required to, even our family medicine ones are not required to have that training, but most programs do offer it. And so I just wanted to share that and kind of remind us that our doctors, our physicians are trained in this, and a lot of our APPs are trained as well. And I know we just had a question about APPs getting trained in abortion care, but beyond that, just in terms of providing reproductive health care as well, there are a lot of training opportunities for our providers. So at Melody Health, I know we've been talking about this, how it's so much more broad than abortion. And as John mentioned, that's 7% of what we do at PPOSBC is provide abortion. But the other 93% is providing comprehensive primary care and reproductive health care. So, we provided nearly 17,000 abortions last year. But in comparison, we provided more than 400,000 STI checks and testing. We had nearly 50,000 visits for birth control. Contraceptive visits, including emergency contraception, is a big part of what we do, and it's a big for our Melody Health patients and all of our patients. Our well person visits, including pap smears, that is reproductive health care, but is provided as part of our primary care program. cervical cancer screening and testing. We do provide behavioral health. We had nearly 4,000 visits for behavioral health. And we also provided 4,000 HPV vaccines. And I'm sure a lot of our centers on this call and providers are doing the HPV vaccine for their kiddos and their peds patients. So again, that is when we're talking about reproductive health care and that being part of primary care. So I wanted to talk a little bit about STI testing and how that is such a big component of what we provide at Planned Parenthood. I wanted to share this with you. In 2018, we really started to see across the country a huge increase in chlamydia and gonorrhea cases. So what we decided to do at Planned Parenthood is go to an opt-out model where we actually do chlamydia and gonorrhea screening for every patient that walks in our door. We started that in January 2017. And it was, again, due to the high prevalence rate at our health centers, but just across the country. I was looking back at the statistics and reminded that chlamydia had increased 56% in 2018. And then gonorrhea, the rates were up more than 200% over the previous few years. And so that really became a top priority for healthcare providers across the country, and particularly in California. And for us, we were finding that we had a pretty high prevalence rate and a positive rate. And so we went to this model of testing every patient that walks in our door. Last year, we performed 159,000 tests. So what's really interesting, if we show this data with you, the chlamydia and gonorrhea rates, though I go back here, our increase in the testing, we increased by about 3% in the number of tests we performed. And our volume over that year has increased greatly. So really that number value increased quite a bit. And if we look at the positive rates for both, they've stayed pretty consistent or gone down just about 1%. So chlamydia from 2018-19 to current has gone down about 1%. So we've increased the number of tests, but our rate has only decreased 1%, which shows that how important it is that we continue with this policy of testing every patient that walks in the door, because if we didn't, we would clearly be missing a lot of positive cases. And just wanted to share, we provide, we test every patient and we have our own lab. But for those centers that don't have a lab, it's just a matter of putting in a referral for that patient to go and get a test done at their contracted lab. That's all that we're talking about. It shouldn't be really a huge change in practice or in operations or in the workflow, but just being able to have that conversation with patients, identifying those patients that are at risk, knowing that the rates are so much higher in that that age population that a lot of us are seeing, and just making that part of our standard care, standard practice. So how have we done this? Of course, we've done the opposite, right? We were a reproductive health care provider, and we started to integrate primary care into our practice. So it was the opposite, but it's the same concept. It's this idea that we've been talking about, that providing reproductive health care is part of whole care for patients, and part of the primary care spectrum of care that we want to give to our patients. And what I wanted to share were just a few sort of lessons learned and best practices and observations that we've made. Of course, advanced practice providers, which I know staff a lot of health centers, our federally qualified health centers, and for our safety net patients, we they provide a full range of services, as I was mentioning earlier. And for us, we have 12 family or eight doctors that provide primary care, and then we have about 15.5 FTEs that are in total providing primary care. So a lot of our APPs are providing both, and so their day is split. They are doing some primary care and they're doing some reproductive health care visits. And one thing that we have sort of this lesson learned is that template management is very important, which we all know as we're running health centers is is such a challenge, but is so important. But in this space, it is as well, because of course, the visits for a primary care visit for especially a really complex patient, that might be a really long visit. The nice thing about doing a family planning visit is it can be a really short visit. Doing an infection check is pretty quick. Seeing a patient to write a script for birth control can be very quick. And what we have discovered from our providers is that they really like having that mix. And so they might spend 2/3 of their day doing primary care and a third doing family planning. They might have a full day that is family planning, which of course works in our setting. But I would really encourage, as you're thinking about how to do more reproductive health care, or to even think about how you're probably already doing it. I'm sure a lot of our health centers are already doing these birth control visits. We're already doing pap smears. So encouraging you to think about how you're already providing this, and then think about how you can do it more and it not seem like such an operational burden. And I do think that, as I said, our APPs have shared with us that they really like having that mix, and they like being able to look at their schedule and see when they're going to, have a lot of sort of these shorter, easier visits. And from the template management that I was talking about, what we've been working on, because at first it was, very much as we started to do this program and incorporate it, it was very much kind of this free for all. And so we've really tried to recently start to drill down and provide a little more structure without, of course, having to balance patient access, but provide a little more structure so that we can help the providers have that sort of optimal day and see the highest level of patients that they can, so that our access is good for our patients, but then also be able to manage their schedule a little bit more. And I'm happy to share more details about that with anyone, one-on-one. The other thing that I thought was important for us to talk about is, because so many of us are involved in, looking in the horizon for this shift to value-based care and in population health. And if when we're talking about any type of practice change or operational change, we all have to have those lenses on and be thinking about that in coordination. So when we're talking about this shift to value-based care and population health, really the emphasis is on the importance of the whole person healthcare delivery. And the care delivery model, it must align with a reimbursement structure, of course, and then the entire system must be working and coordinated to align the financial incentives with the points of care. And I wanted to just give an example of that last point as we're talking about operations here, something that we have observed and am looking through at PPOSBC, and that's our mammography referral process. So our burning platform was that we were not meeting the quality standard for breast cancer screening. So we implemented a 6-week Plan Do See Act to close the care gap and increase patient completion of mammography. Our intervention for this was we utilized a patient navigator to communicate with patient about the CalOptima incentive program for getting their mammogram done. And then we changed our internal workflow for getting that form completed and for reaching out to the patient. And what we discovered, beyond just our own internal barriers and workflows that we had to address, but there were the external factors that were happening outside of our own organization. And that was really the barrier to care at the contracted imaging centers. So imaging centers were scheduling mammograms approximately 5 weeks out. We all know that the longer the appointment is scheduled for any healthcare service, the higher the no-show rate can be. One payer that we are contracted with was no longer contracted with the imaging center that was closest to our health center. So that was definitely is causing some access issues for our patients. And then difficulty accessing care and communication with the contracted radiology group. So like many of us, and a lot of providers are short-staffed and there were long wait times. And so we ourselves were having a really hard time getting through to the provider. And of course, our patients were as well. And so as we sat down and we started to think about how we could support our patients with getting their mammograms done and identifying sort of this external barrier that was happening, and really thinking about the shift to population health management and value-based care. For all of us, none of us want to be financially held responsible for the outcomes for patients that we don't have any control over. And so this is definitely something that we're going to continue to need, to sort of this whole system approach to improving care and providing and aligning as incentives. So just a real quick summary, and as we've been talking about in the panel before me, integrating reproductive health care into primary care is operationally achievable. We've done it for 10 years. Like I said, we did the flip, but we have done it for 10 years. As you can see, our volume has grown tremendously. And one of the big takeaways for us was that template management is really key. Reproductive health care is an integral part of taking care of women's total health for many years of their lives. And if you're seeing patients that are between, in their reproductive health years, between 18 and mid 40s, then you are providing reproductive health. I mean, I don't know how you provide primary care and how you provide care to them if you're not providing some level of reproductive health. And it's good for business. I don't know, many of us have heard the statistics, but we probably all know this to be true anyways, anecdotally, that women make 80% of healthcare decisions for their families. So the truth is that when we are providing excellent care to women in our practice, they are then able to make really good healthcare decisions for the rest of their families, whom we're seeing as well. And for those health centers that are doing primary care for the whole spectrum of lives, the better care that you're providing to the moms in your practice, then they're going to bring their peds patients in, they're going to bring their kids in, and they're going to bring their partners in for care as well. And then the last point that I was, talking about earlier was the shift to outcomes and population health-based care will require an integration of the whole healthcare practice and coordination of all points of care. So as we think about integrating reproductive health into primary care, really looking at all of those outcomes, like I said, we were looking at the STI rates. As we do that, as we look at our unintended pregnancies, all of the different outcomes that we look at for our patients, it really is going to take a real coordinated effort by our whole healthcare system. So I sped through that. Here's my email if anyone wants to reach out, and I will stop sharing. I can figure out where it is here. Okay.
Thank you, Krista, so much for all that you've shared and a real life example of how it's done here in our county. I don't see any additional questions coming through, so I'll look to see if maybe I'm missing one before I move on. Otherwise, I will move to close us out today. Again, thank you to all of our speakers today. Your insights, expertise, and passion for uniting together to advance equity and embrace reproductive health as essential to holistic care is so inspiring. Each and every one of you has contributed significantly to this discussion and really inspires me personally to continue to do the work that we do to move the needle on this and to normalize this discussion. I'll summarize a couple of points that all of you made. So our keynote speaker, Amy Moy, reminded us that reproductive health matters and is essential because everyone should have the freedom and power to control their own body, decisions, and lives. It is important to pause as we look at the state-by-state abortion access map, as we think about the numbers and the millions of people and lives impacted and how it is impacting everyday lives. Women and pregnant women who are unable to get the care they need will face negative consequences for their lives, paths, health, and economic security. She reviewed the historic package that was passed to protect and support access last year, the $200 million invested in the state budget for fiscal year 22-23, all of the essential new programs that came with that, the 15 bills that were passed and signed with provider and patient protections, and the fact that the state actually took action to create a back-end system for FQHCs to get reimbursed for Medi-Cal reimbursement outside of the PPS rate, should they decide to move in the direction of wanting to provide these services. As I stand now, I don't think any community health centers in our county are moving in that direction. A couple did explore it, but as far as I know, there is no one looking to do that. But given the question that we got today, that number may be changing, or that there may be a shift in the line of thinking there. She also emphasized that that it's time to stop fighting and start caring. So this is a marathon, not a sprint. It impacts all aspects of life. Therefore, the broad spectrum of reproductive health is not only essential health care, but life care and life-changing care. Thank you so much, Amy, for all those inspiring words. Assemblywoman Kari Petri Norris started the coffee chat with a powerful statement. California is fighting back and we will not back down. That again is very powerful, coming from a leader, an elected leader in our state who really has taken the bull by the horns, if you will, on this topic. So we appreciate you so much for what you do day in and day out for us Californians. During the chat, our speakers shared that we need to normalize reproductive health as primary and essential, and not something that's on the side. This includes the integration of STI prevention, integrating access to the full spectrum of birth control. It doesn't and it shouldn't matter what administration is in place. We need to make sure that we have the policies, funding, and education in place that do not harm. How do we reimagine what the workforce should look like? How do we allow folks to work at the top of their license and or expand their scope of practice? Again, it was reemphasized that healthcare is a human right. I think we're all on the same page on that. And that patient-centered care, we need to think about the person in front of us and the humanity of the person, as well as meeting them where they are in order to provide the best possible services that they may need. And then in terms of policy, we need more investments in policy around workforce development. Again, in California, we've done a tremendous job in expanding reproductive rights, but rights without access become meaningless if we don't have the right workforce and capacity there to meet the needs of patients. During our reproductive health in action, Krista shared with us that reproductive health care is a whole person care. They encouraged us to look to integrate and use the template management as a tool, shifting to population health and value-based care. When talking about practice change and operational change, we need to have a lens and emphasis on whole person healthcare delivery, and will require integration of whole healthcare practices and coordination of points of care. Thank you, Krista, for all the great examples that you shared on how integrating reproductive healthcare into primary care is operationally achievable and doable, and you're doing it. So thank you. And so again, thank you again to all of our wonderful speakers. Thank you to each one of you for participating in our third Coffee Connections event. Stay tuned for our next event scheduled for December 8th of this year. Each of you will be receiving a survey where you can share your thoughts on Coffee Connections. And if your organization would like to sponsor our next Coffee Connection, we'll be putting a link in the chat. And with that, I will say, have a great rest of your Friday and have a great, wonderful weekend. Thank you.